collaborator and friend of ours. Marley will be talking about chest X-ray, which she works with quite a bit.
Yes, so I'm going to talk a little bit about chest X-ray. Just for my idea, how many radiologists are in the room? Okay, quite a bit. Those are not the ones who are going to answer the questions first about the X-rays we're seeing. Makes it a lot more fun. So we're going to talk a little bit about X-ray basics because that's important to know if you want to do any AI on them. We're going to talk about clinical indications for chest X-rays, and then we match that with some of the AI use cases and opportunities. And then we're going to talk a lot about X-ray views, image quality, and how to use X-ray data. I'm going to leave a little bit for the lecture after that, so that's going to be a really short one. So X-rays are fairly old. The first X-ray was made in that is 90, it's probably 80, 95, not 95. And the first Nobel Prize was in 1901, so they're fairly old. This is a picture of the first X-ray ever made from Röntgen's wife. So they are basically high energy photons traveling in waveforms, speed of light, and they're highly penetrating. So what we need to know about X-rays, they can be absorbed, scattered, or passed through tissue. So low density tissue allows more X-rays through, so they're shown black. High density tissue has less throughput of X-rays, so they're white. You can increase the strength of your X-ray beam to increase penetration. That will make the X-rays go deeper through the body, but it also turns out blacker and you have worse contrast. So those are sort of very quick basics. We started with conventional radiography on film, and I'm sure some of you have seen this in movies where they walk around with these nice pictures in hand and put them on a light board. A lot of the things we see in X-rays today stem from that time. So now we do digital radiography, so we don't walk around with pictures, we don't have to make them in a dark room, it's all digital. You have computed radiography, which needs a cassette and then you move it. Most of what we do now is direct radiography, which is convenient. You have different window settings for depending on what you want to look to, and it's all digital. So again, this is a chest X-ray for people who has never seen one. You have air, which is really dark, soft tissue, which is sort of grayish, and then bone, which is white. And then the main things on an X-ray, I don't know if you can see the mouse if I move it, yeah, are lungs in green, yellow. This is your trachea, that's where you breathe through, and then your heart in red. So that's basically the main organs, besides bone and soft tissue, that we look at. So when we think about clinical indications, there is a massive amount of X-rays taken in the US, 70 million chest X-rays annually. One X-ray is currently equivalent to 2.4 days of natural background radiation, and that's part of the point why they're so popular, is they're very low in radiation. So you can do them a lot before the radiation you give to people become dangerous. Another part is that they're just cheap. This is from our pay registry. So you can see these are all X-rays. This is 1 view, 2 view, 3 view, 4 view. The max you pay is around like $100. If you look at CTs or MRIs of the chest, they go up to like 1,000. So that's one of the reasons why we like making them. What we do have to keep in mind is that X-rays this is like a nice 3D, well, nice. This is a 3D model of a dog. X-rays are sort of like the draw 2D version of that. So they're great because they're fast, they're cheap, and they don't give a lot of radiation. They're also not super high quality. So normally people look at X-rays according to these A, B, C, D, a whole lot of letters. I did 2 years of ICU medicine. We normally stop after C. It's airway, breathing, cold colleague, and then we're done. But most people, yes, I'm sorry. Most people, especially radiologists, go through all the letters. So it's for airway, bones, cardiac, diaphragm, effusions and extrathoracic, soft tissue, fields, fissures, and foreign bodies, great vessels, the stomach, and then hilum and mediastinum. The reason why I wanted to show these is because you can see there's a lot of this on this X-ray. Don't need to learn all of it, but all of these things we can do with X-rays. So for all of these, there are clinical indications why we take these X-rays. I tried to group them in elective, emergency department, and intensive care unit. So if we look at elective chest x-rays, they're planned, non-urgent, and most of the time they're outpatients, which means patients need to be healthy and mobile enough to come to your hospital to get the x-ray. And this is important for later on, but a lot of it is chronic disease, chronic respiratory symptoms, chronic lung conditions. We do some monitoring for cardiac disease, pre-op evaluations, occupational health screening for asbestos and those sorts of things, lead paint we sometimes still do. We do some screening in high-risk patients. If you smoke with history of malignancy, we screen them sometimes with x-rays, and then for unexplained symptoms. Most of what we do is for diagnostic purposes, so we do a lot of detection of disease, segmentation or quantification of abnormalities, and then a part of it is opportunistic screening, where we do an x-ray and we can sometimes see if they are at risk for other diseases or we see other things. This is a normal x-ray. This is another normal x-ray. So they're not normal, but this is definitely, the left one is not a normal x-ray. They're from the same patient. They are taken 3 months apart. So what we very often do for x-ray, we look at timeline based. So you try to look at an earlier one to see if things change. And then if you spot things that either appear, you know it's an abnormality. If they disappear, you know that probably your treatment was working. So in this case, it was a pneumonia. They got treated and this looks better. So very often you have multiple x-rays. So if you want to use AI, you have to see, depending on the disease you have, if you want to use one time point, if you want to use multiple time points. There are some AI applications that use longitudinal chest x-rays report to refill the next report. It saves you a little bit of time, especially when things are already present in the x-ray. Let's see. So this is the most common AI algorithm that we see for elective x-rays. This is just an example, but they detect a multitude of disease. We started with anomaly detection where it was like, okay, this is abnormal, this is normal. Currently, there's a lot of algorithms that are FDA approved that can detect a lot of disease. They put these boxes around them to localize them. So this is not uncommon. You can do that with pretty high accuracy. And then we have a lot of these screening for lung nodules. Again, this is a lung nodule here, and the algorithm just points it out, gives like a malignancy or abnormality score, sort of alerts the radiologist to look at it. The reason why we do so much lung cancer screening with AI is mostly because of these things. 16.7 million after missed lung nodule on a chest x-ray. Over 200,000 cases of lung cancer are overlooked due to malpractice alone, and this is the US only. It's the 6th most common malpractice issue and the 2nd most common cause of litigation amongst radiologists. So there's very high incentive, so that's why there's a lot of AI development, because it saves hospitals a lot of money and it saves you a lot of lawsuits. There are some cardiac things. So this is based on if you have an enlarged heart. So what they do is they measure the lungs. So it's a fairly simple segmentation algorithm. You segment the lungs, segment the heart, and look at the ratio. If that ratio is larger, it's indicative of cardiac disease, especially the cardiomyopathies and heart failures. And then we have the emergency department. So this is a lot of acute disease. So these patients are in stress. You want to image them fast and you want to act fast. So it's acute respiratory symptoms, pneumothorax, pneumonias. If you cough up blood, that's an emergency thing. Trauma, so a lot of bullet wounds, car accidents, bike crashes. Foreign body detection is mostly for children when they swallow or inhale things. Acute cardiac conditions, and then we have the unexplained acute symptoms that don't belong anything but are acute for the patient, so you want to do that fast. Again, we see a lot of detection of disease and a lot of segmentation here. I think COVID definitely caused a boom in this area, where we see a lot of studies on pneumonia, COVID pneumonia, where these patients come to the emergency room. You want to know, like, do they have a pneumonia? How bad is the pneumonia? So you would have these images and be like, this is a very mild pneumonia. This is a pretty severe pneumonia. So you want to be able to separate those so you can do that. For pneumothorax, there are some clinically implemented where you see this is again a semi-normal. We don't have a lot of really normal x-rays in my data set. So this is semi-normal. And here you see no air markings, which is a pneumothorax. And I'm pretty sure if I show you 5 of this, everybody in the room can detect this. This is not crazy hard. It becomes crazy hard when it's like this. Any of the radiologists want to say something about this one?
Clinical correlation required.
The lights are on and it's not the best screen, and I know what it is, but we're looking at this very tiny line here. So it's a small pneumothorax. If you have high volume data, or if you're a resident, if you work at night, sometimes these are missed. So there is some AI development that points these out, that line. And why it's very useful is for clinical workflow prioritization. So a lot of these algorithms, they just flag the emergent cases where you're like, hey, this patient would benefit from really early treatment, and they put them higher on your reading list. So here, normally, it's like first in, first out, like you do in supermarkets. The first patient who get x-rayed get read the first. But if you have 5 normal x-rays and you read the 5 normals first, then the 6th one that might have a super urgent disease has to wait until you're done with the 5. So what sometimes happens is they put an AI algorithm in the beginning and flags, hey, this one is super urgent, read that one first, and it reprioritizes your work list. And you have active prioritization, and you have widgets that just notify you as, hey, look at this patient. And the idea is that you would improve outcome by prioritizing your urgent cases. And then a specific type of x-rays are the ICU x-rays. So those are not as much for disease detection as for monitoring of disease. And it's especially useful when you have patients who are either on ventilatory or cardiac support. So we check if their lungs are doing better or worse with the treatment. You check for complications of their ventilation or cardiac support. And a lot of these patients get an x-ray every day, and they definitely get an x-ray once new lines or tubes are placed, just to make sure that they don't cause any complications and that they're in the right spot. So what we've done, this is some of our own work during COVID. What we've done is tracked x-rays over their ICU stay. So for example, patient 1 came in, had very mild disease and progressed, got worse over days and passed away, had 4 x-rays done. And then we had 1 patient who came in with mild symptoms, got really bad in red, and then recovered. So we tried to track that and see what happens at these points where patients recover, or what happened that these patients die, and can we predict the next phase in their x-ray? So that's the long-term monitoring that you get from ICU, where patients most of the time have more than 1 x-ray. There are algorithms out there for line and tube detection. It is very time intensive to do the line and tube detection. So when you do it for ICU patients, you do them a lot. You very often, people at the ICU look at them before the radiologists look at them. You have to maybe change a tube or pull it back a little. It's not super hard. It's just, you have to do it. So there are algorithms that like point out where the lines are. So it makes it easier to very easily track them, speeds up that process a little bit. So the labels you train these algorithms on depend on the task. So you can use lab values, CT or MRI imaging, pathology, radiologist opinion. No. Outside. Okay. We're more than happy to discuss them, but I don't have a lot of examples of them. Okay. So it depends which label you use, if you want to do presence or severity. Radiologist opinion, we've done studies on it. There's a lot of variability in there. So if you want to do presence, you're probably good. If you want to do severity, you want to take into account that more experienced radiologists are more often more comfortable saying this is normal than younger radiologists. So you have a varying group where you train on. Pathology would be ideal, but for a lot of diseases, you don't necessarily have that. So sometimes you want a combination of these things. So this is a case where we have an x-ray. And there is an abnormality on this X-ray. It's way better visualized on this CT. So here you can see this mass here. It's behind the heart. It's sometimes easy to see. It's very easy to see on CT. So sometimes you want to combine these two image modalities or use CT as the label, depending on what you have present of these patients.
Just one comment on this one. You're going to publish the report as AI is better than radiologists. That's not like a true apples to apples comparison, because they would also pick the abnormality on the CT scan. I think that was a common error of mistake earlier on. And what it does is that, I mean, this is a great use case where you find a good machine-human combination, but if you start publishing that type of work, then it builds a little bit of distrust in the radiologist, because it's almost like more than the combination that's there.
Well, and I think the point is that the reason why we do X-rays is because they're done earlier, faster. So very often when a radiologist look at it, the CT image is not done. The CT image is done when a radiologist says, hey, there is something worth making a CT. But since we train retrospectively, if you want the best reference standard, see if there are CT or MR images. But it doesn't necessarily translate to clinical use one-on-one, because that CT images won't be there at the same time.
And also consider the duration, right? So if it's a malignancy, right? Because sometimes you won't have chest X-ray and CT on the same day. What's your practice? Like, is it within 3 months span, or is it pre or post, right? Because those
Yeah. So
we'll talk a little bit about that.
for us, it's disease related. So for COVID, right, if you say COVID severity, you want a CT within like 24 hours, because if you see a really bad X-ray, you probably give medication right away, and then your CT is not representative anymore. For lung nodules, we assume that they don't grow overnight. So then you have a little bit of leeway with your CT. And I think that's why it's very important to have discussions about like, hey, what disease are we looking for? What exactly are we detecting? What would make the ideal reference standard? And that's why it's important how you look at X-rays. So these are some of the things we look at before even diagnostics. And I think we mentioned anonymization. We ran into this issue, is that, again, X-rays are from the early 1900s, where you had film and where they would stamp the actual time date into your film, which was great. Like, when I was young, you still had to develop those picture image rolls, and you would had a year on it. Now we have digitized radiographs, so you would say that they would get rid of all of that and put it in the DICOM header, but they don't. Emory, and I'm sure a lot of hospitals, still stamp their X-rays with dates and times. This is fake, but because I cannot just show times and day. So what we've done is like create an algorithm that removes them, but you can see it here in the image. It causes a little bit of blur. You can see it especially when it falls over some of these metal things. We started with black boxes, but your AI algorithm just focus on that. And then when you take images from another data set, for example, you take the RSNA data set or the NIH chest X-ray data set, and they don't have that, it's very easy to say, hey, we take normal cases from the RSNA data set, disease cases of us, we had 100% accuracy. My students are great, they're not that great. So we're like, okay, it might be this box. You do like a sanity check in between with a heat map, and yes, everything was focused on this box. So it is important to know, hey, did somebody do this? Was it done on all X-rays? How did they do it? Do we have to recreate this on different X-rays when we merge data sets? Anatomical planes, so X-rays are 2D. I don't see 3D. I had eye surgery as a kid, so 2D planes, if you combine two, you sort of get 3D information, but basically what you get is like two flat images, so you need to know in which line they're done. So most of the time you have like the sagittal plane and then the frontal plane, so it just makes a cross to the image. So you can see sort of both sides, and then you have a transverse plane. For X-rays, what you basically need to know is that anterior is the front, posterior is the back. Right, left is a very tricky one. If you ever have a radiologist navigating and they say go left, you might just want to turn right. because of it's a projection, the left and right are reversed. And I know this from experience. I have had fights in the car many, many times. So there are two basic types of machines for X-rays. We have wall-mounted. So this is a wall-mounted. You can see there's nothing on this X-ray. This is done by a machine that is fixed in a room. So these very often are patients, outpatients, that come to the X-ray machine, which means they are in pretty good health because they're able to come to the hospital, to walk into the hospital, to stand and to maneuver, hold their breath, everything. This has an effect on the quality of your X-ray. On the other side, we have these where it says portable, and we can clearly see that this patient has not been standing because it's in a weird angle. There are other ways, but we can talk about that later. It doesn't say portable, but we know that this is a portable X-ray. So these are machines that go to the bed, and these are for patients who are not able to get out of bed and stand. So this is a lot of emergency department or ICU or surgery sometimes uses these too. Sometimes we call them buckies or portable X-rays. You need to know that because there's a difference in image quality. And then there's different views. So we have an anterior-posterior view. Again, you follow the X-ray. So posterior, anterior goes from the back to the front, and anterior-posterior goes from the front to the back. You would say, on basic principles, if you go back to front or front to back, you should have the same image, just the other way around. That's just not the case. So posterior, anterior is we hope to do that on every patient. It also means that your patient can stand. So they're often standing, they're the best image quality. You have clearer lung fields. Most of the time, the anterior, posterior ones are the ones where they're laying down. So they're most often done with a portable one. So that lowers your image quality, and your heart size is bigger. The reason for this is, if we look at this, I draw this very nice heart in, is that the distance between your X-ray source and your heart. So if you look at the posterior, anterior views, if I would have a mouse, I could show you, but I can do it here. This distance is longer, but if you scatter your photons here, you have less scattering because you're closer to the plate. Here, this distance is shorter, but you have more scattering because it scatters on this heart. And it works very similar to this light shadow thing that you do as a kid when you try to make figures on the wall. Is you get a larger shadow when your toy is closer to the light, and then you get a smaller shadow when there's a long way. So if you go here, there's a long way, so you get a smaller shadow. And here, there's a short way, so you get a bigger shadow. So you have to take that into account. First quiz question. This is same patient. One is an AP, one is a PA. So one is front to back, other one is back to front. Anybody wants to make a guess? It is a portable, but both are portables. And one is an AP and one is a PA. Let's go from the left one. Okay, I have to do this because I don't know what left is. Wait, what? This one is the why? Yeah, you can also tell by that the lungs are slightly darker, and that you have less space here. Like your diaphragm is a little higher, and that's from the back to front or front to back portion of it. And then, because we like to have 3D information, we try to get a second view, which is a lateral view. So we split the body the other way. So now here you see your vertebra, your heart. So you're just basically looking from the side. You can see it here. We call this a left or right lateral, and they're left or right based on which side of your body is touching the X-ray plate. So this is from a stand-up patient. It allows viewing behind the heart, and then you can see like the diaphragm. This one is called a lateral decubitus. it's basically scanned from the front while the patient is laying down. And it's very convenient when you look at mirrors of water. So here you can see like water in the lungs, gravity does its thing, it flows down, you see it way better on this view than you would see it standing up or laying down when it sort of disperses all over. So very often you like to have two views to get 3D information or to see if there are any liquid lines moving. So this is an example where we see here these lines. It's a mass, but it's behind the heart. So if you have a lateral view, it's easier to see where it exactly is located and what you're looking at because you just get the two planes. And then again, months later, this X-ray was taken. It's way clearer that, but it makes a nice reference that it is in the middle behind the heart. This is a case from Radiopedia. This is my favorite site if I ever need to teach students something or need to look up a case that I've never seen before. This is my place to go. So vague chest pain. I will not make this a question, but this is a pacemaker. Luckily, most X-rays don't have enough image quality that we can see the serial number. On CT, we sometimes have to anonymize the serial number of the pacemaker out, but for X-rays, we're good. There is this shading behind the pacemaker, which is hard to see what it exactly is. In the lateral view, you can see it way better. It's this dome. And again, it's just 3D information makes your life easier, but if you want to use AI, sometimes you will need to give both views, and that depends again on the disease. And Judy already said, like, DICOMs are your friend. It contains all of this information because we don't have to all learn this. So it already says here, this is a chest, two views, posterior, anterior, plus a lateral standing protocol. And then if you go into the individual study, so this is for the patient, and then you can go into the images itself. It says this is a PA and this is the left lateral. So you can get that information from your DICOM headers.
Sometimes.
We'll get back to that. There are some really good examples of exactly your point, probably. Okay, so then the second thing we look at is inspiration, expiration. Inspiration, again, is our clinical norm. It decreases the attenuation of the normal lung. You can tell the inspiration by counting the ribs. There are just cases where expiration helps, especially because it increases the contrast, for example, between lung and pneumothoraxes. So for specific situations, sometimes we do an expiration. You have to take into account that your cardiac silhouette is a little bit wider because of the expiration. So if you look at things like we looked before, is do you have an enlarged heart? If it's an expiration X-ray, there are different reference values. So you can say it's enlarged, but is it because it's an enlarged heart or is it because it's an expiration X-ray? And that's why it's important to note these things. Next quiz question. Same patient, inspiration versus expiration. Which one is what? So you're saying that's inspiration? I'm happy. Yeah, good job. I mean, I would be a little worried otherwise. But yeah, you can see is you have more ribs on the inspiration side, the lungs are darker, and you see the heart silhouette here slightly larger. Yes. No, so the views are in this is not. So that's why it's counting the ribs and seeing how dark it is. And of course, it's way easier when you see them next to each other. What you do sometimes see is in the requested procedure description, they sometimes mention if it's an inspiration or expiration, but it's not standardized. So it's just a text field, which makes it a lot harder to do. And then you have patient positioning. So again, it's super nice if your patient can stand and you can get upright or erect. Again, these are burned into the image. These are very often are in the DICOM descriptors. And this is exactly what Harry meant. This says upright. I just queried our database for upright or erect X-rays and I got that one. I'm pretty sure this patient wasn't upright because he has a ventilation tube. And also, he looks under an angle, if you can see like how you look at the tube and how you look at the collarbones and the ribs. This patient was definitely not standing, but your DICOM tech will say that it does. So it's always good to have a little bit of a sanity check in some of your data. If you have outliers in your accuracy, or if your heat map shows something weird, it's good to sometimes go over that. We sometimes make a slideshow of all of our wrongly predicted cases and just go over them if we see things like this. We have semi-erect cases, so these are patients, sometimes it's called semi-sitting when they're sitting. Most of the time, semi-erect are patients who are in a hospital and they just put them slightly under an angle, so they're half sitting, half laying down. It will say semi-erect. So you can see these patients are often more diseased than your erect patients. That's why they're laying down. And they're done under an angle. And then you have the supine and the prone patients. So these are patients that are laying down, and supine means stomach above, and this means back above. We've seen the prone cases a lot during COVID because they would ventilate in this side, because most of your ventilation or perfusion takes place at the back of your lungs, and then gravity doesn't work, all the liquid goes down, and then your lung fields are more free. So they put patients there. So during COVID, you see a lot of these prone. Normally, we see a lot of the supine ones if you look at ICU. And this matters again because with the APPA, light goes through the different way, or the photons go through a different way. So you will have slightly different densities and measures. Some of the heart contours will be bigger or smaller depending on the size. And again, these are patients who are not able to be in a semi-erect or standing position. So they very often have either ventilation tubes, surgical things. They are diseased. This is, again, a Radiopedia example from a bicycle. I had a bicycle fall yesterday. That's why I was like, I need to put this in. 35 female, this is not me. So you can see here, this is, I'm going to tell you, a pneumothorax. They're done on 2 different positions. So it's a supine, this one, and an erect one. Here, it's a very subtle pneumothorax. Here it isn't. You can see here there's no lung markings. This is the line. So based on this one, they were saying, hey, this is a very small one, but let's do another X-ray standing. And they saw, oh, this is big enough to put a drain in. So based on this X-ray, they didn't think they needed a drain. They put in a drain in because of this X-ray. So again, depending on the disease, you sometimes need to use different positions of the patient. And that's where you need to have some clinical collaboration that say, hey, if we're looking at pneumothoraxes and there are different views, we might want to use both or the one that's more clinically relevant. Again. Patient positioning is especially tricky when you look at the emergency department or the ICU. If patients can stand, you're most of the time able to instruct them to stand very still, to hold their breath, to not move. They stand up straight. In ICU, very often, especially when they're comatose, you just struggle to get the plate under and make an X-ray. So they are in really weird positions. Sometimes not the entire lung on there, you get other things on there. So you have to take that into account, that if, for example, in this image, there is part of the lung missing here. So you cannot say that there's no disease there because you don't have that part. They look different from normal X-rays. Sometimes, again, they do multiple X-rays because here the top is missing. They do a second one. You see a little bit of the bottom missing. So most radiologists would read both to get total information. Again, if you want to use AI, you have to give them both, or you have to accept that you're missing part of the lungs. Okay, so I've mentioned it throughout, but why is this important for AI? Because I don't want you all to be radiologists and teach you how to read it. But this is something that was drained into me. Absence of evidence is not the evidence of absent. Just because we don't see things on X-rays or we don't find things on X-rays doesn't mean it's not there. It just means we don't see it. There are 2 ways for this. One of them is missed findings. Radiologists are humans. Sometimes it's right behind the heart. Sometimes it's in a missed spot and you just don't see it. Or it's just not the right acquisition. So we want to make sure that that we miss it, not because we're looking at the wrong view or the wrong position, but because we actually don't see it. And another thing is, and this is Dr. Gacho's study, there are things that we visually don't see on X-rays, but there is data of. So they predicted race from X-rays. I don't know, I can give it a shot. I'm pretty sure I'll be really bad in predicting race of X-rays, but AI apparently isn't. So just because we cannot see things doesn't mean it's not there. And that's why you need to be really sure that you sort of exclude variability between your different sets that are due to patient positioning, the different views, or how you take them. And one of the things is, if these are your normal X-rays, these are all APs. They look pretty good. This patient is standing up straight, no weird wires, cables whatsoever. And you compare that to your disease that are all semi-erect and portable, I can split these groups very easy. Your AI is not going to have an issue with that. If it looks at disease, probably not. It probably looks at all the other things that are different at these images. So if you want to merge data sets, or if you want to merge groups, you want to make sure that you're looking at the thing you're intent to look at. And then there's a lot of foreign objects that will mess that up even. Does anybody want to describe what they see on this image? I know you can see it on this one. This is not the spine, but there is metal. Yeah, so these are sternal wires. We see them when patients have open heart surgery. They put a drill through your sternum, it goes open. It's very hard to close, so they put in metal wires to close it again. They don't take them out. They're there the rest of your life. They'll show up on every image, so if you ever see this, you know this patient had cardiac surgery. Anything else that is noticeable? Yeah, so here you see these little metal dots and wires. That's an aortic stent. So you know this patient had cardiac surgery and had aortic issues. If you are predicting cardiac disease, and I've done this, I've tried to predict, in 2016 was my first AI algorithm, epic fail. We had 100 patients and we tried to predict myocardial infarction from X-rays. I had like 99% accuracy on 100 X-rays. I was very proud of myself. And then I went to look at the data. I was very good in predicting sternal wires. Which, let's be very honest, if you have sternal wires, there's a very big chance you had either bypass surgery or what. So it might not be the worst thing, but you didn't see myocardial infarction. You see sternal wires. It's the same with these pacemakers. So here you see a pacemaker. This is the pacing wire. It's in the heart. If they're there and you're predicting cardiovascular outcomes, most of the time people with pacemakers have worse outcomes than people without pacemakers. You're not looking at actual disease, you're just looking at the presence of a pacemaker. Same if you're predicting lung disease. I mean, we can all tell this patient's lungs, they're here. They're not filled with air. But we can also see that there's a lot of wires. There is sternum wires here, and these are the ventilation tubes in which they go to the machine. So there's a lot of other things that your AI can focus on besides these lung fields. I'm curious, I have to admit, I'm not a radiologist. I missed this one until one of the radiologists who did my labeling was like, Marley, you want to remove this from your COVID database? Anybody sees anything weird in this image? It's pretty subtle. Sorry? I mean, to be very honest, I don't think this is necessarily obese. This is just a woman. But this patient, for our intents and purposes, is actually not that obese. Like, there's not that much fat here. Yeah, there are butterfly stitches. This patient had a lung transplant. So they're not the best to use for COVID prediction, because lung transplant patient with COVID, they do worse, mostly also because they had a lung transplant. So sometimes there are very subtle things that you don't necessarily think is important. So it's good to have radiologists at least go over some of your cases. We added an other box with our labeling, so just they could sometimes say these things. And then there are foreign objects that shouldn't be there. These are bra wires, and you can see the clips here. Normally, patients are asked to take that off, but sometimes in emergency situations or during COVID in the ICU, oops, it happens. So you have to sometimes work around these things. We see some necklaces. This, for me, this one threw me for a loop. So we take point of care pictures where we take actual photographs of patients in while they do the x-ray, so you can look back and see how did the patient look and how are they positioned in bed. When I saw this, it took me a little while to figure this out, so I'm curious if anybody has any ideas of what this is. Close. It's a blanket. It's like not even a heating or a cooling blanket. This is just a normal wafer blanket that they kept over the patient during the x-ray. It's easy to spot that it's something weird because it's like it's everywhere, also like outside of the body you see it. So you know it's probably not a patient related thing, but it messes up the structure of your x-rays pretty bad. So this does weird things when you try to predict things. So again, if you have normal cases here and you try to predict here pneumonia or you try to predict outcome, and here this is an intubation tube, that one, it just matters. This one, you see the whole ventilation machine on there. Here you see the bypass wires. Just something to take into consideration when you make your databases. This is penetration and exposure. So the same with pictures, you can overlight them or underlight them. This one is overexposed, that's why it's white. This is underexposed, it's dark. It sometimes happens. Most of the time they catch it, they make a new one, and you should be fine. Sometimes they don't. If they're both in there, just pick the right one. This is done in a different window, so you can, with the digital radiography, you can sometimes change the windowing. This is done in a bone window. The tricky is this is an overexposed and this is a normal of this patient, over normally exposed. This is again not a normal x-ray, but it is not a super weird x-ray. The tricky thing is this. This is an abnormal x-ray, but it has very similar densities as to an overexposed x-ray. So if this accidentally ends up in your data set, and you're detecting like consolidations or pneumonia, this is gonna end up positive just because it has very similar contrast and intensities as a very, very diseased patient. So you might not wanna use your over or underexposed x-rays. Okay, and then how to use your data. Again, I use microdicom for very quick checks because it allows you to see the whole series, the whole patient, and then get all of your DICOM tags. And this is especially convenient. I do a lot of cardiac CT, and we have every vendor at Emory, and some vendors use slightly different tags. We sometimes use upright or erect, and sometimes you just need to go through a few to know what's in there. So here you can see that it's a chest AP, it's portable. Here it says, again, anterior, posterior. It says that it's a supine one. So you can get these data from your DICOMs, and you might want to do a few. Sometimes what we do is we extract all DICOM tags for the same fields and see what's all in there, so you can have an idea of what you deal with and select your databases on that, so you don't have all erect ones and all portable ones in different data sets. So they can go up to really high resolution, but most convolutional networks don't take that high of a resolution. So we normally resize our chest x-rays, maintaining spatial referencing of the volume. I'm probably one of the only people who prefers MATLAB over Python, sorry. So this was one of the checks x-ray, just like read in. You can get the DICOM info, and then it will give you like the size of the image, says it's grayscale. It's a PA one that I read in excellently. But here you can see the pixel spacing. So if you resize the image, you want to keep this ratio the same just so you don't get any weird reformed images. So we always resize based on pixel spacing of the image. And the second thing is, if you're not used to medical images, is that chest X-rays are single channel. They're not RGB, which is 3 channels. So each pixel represents a signal intensity. It works to scale them to a range, whether that's a 0 or 1 or to a different range. And I'm sure that the next session is going to talk about that a little more. But what I wanted to show, this is one of the X-rays just as an image. This is the intensity, and then if you zoom in, on X-ray data, you just get 1 value per pixel. This is non-scaled, so these are just the intensities as is. If you do this with a color image, I was not that creative. This is a pixel image, you can see the pixels, and then if you go into that, you can see the 3 different values. So those are basically, if you look at it slightly different. So you can do single channel data processing. You can build your algorithm to work with intensity. But when you have small data sets or rare diseases, very often transfer learning is used. A lot of the bigger models are pre-trained on RGB 3-channel images, so you might need to adapt that. So VGG, ResNet, Inception, they're all use RGB channels as input. So you can do, and that's, I think, the easiest way is to go for channel duplication. So instead of having 1 intensity, you just duplicate it. So in the RGB scale, black is basically 0, 0, 0. So if your intensity is 0, you just copy it over the 3 channels and then you get black. So all gray, white, black tones have similar RGB values. So white is 255 by 255 by 255. So if you scale your intensities, you could also scale in a 0 to 225 scale. But basically, that's how you create your gray image. The only thing is, it is not an RGB. So this image, what's the color of this Coca-Cola can? Any? Yeah. Okay, could be. How many people think it's red? You're ruining this.
It's a very famous problem in like human computerization.
Yeah, it is. So how many people think this Coca-Cola can is actually red? How many people believe? Smart. If you zoom in, it's actually not. It has to do that even though we say this is white and white is 0, 0, 0, or it's 255, 255, it still contains RGB pixels. So white is made up by values of all 3 channels, and that's why if you see it in other colors, your brain fills that in. So we forcefully make a color image out of a grayscale image, which if you would give this back for human interpretation, you get these things. Your brain sort of messes with you, and that's something you have to take into account when you go between grayscale and color, is that X-rays and CT data are not grayscale. There's no color in there. If you represent it in RGB, even though visually it looks like a grayscale, there are RGB pixels in there. So this is the overlay, which is from all of these colors. You could also modify the input layer. So you could say instead of height, width, and the 3 RGB channels, you could change the input layer. And then you have to average the weights across the 3 channels. You could also use a radiology-specific pre-trained model. And then there are more creative ways, like this study that says, okay, we just use 3 different filters. So they say, hey, we create filtered images, and then we use each filtered image as one of the RBG channels, and then because you get 3 values from each one, you get sort of a color-coded map, and then you have, again, an RGB image. But then your filter represents other things that might be more specific for what you're looking at. What is very interesting to do, because we've seen a lot of these, hey, this will affect your image detection and recognition, is to look at your filter visualization. So when we build a network, For example, this was for COVID, normal, mild, moderate, severe classification. You get all these filter layers. So this is from like every convolutional layer. Then you can create a heat map and you can compare that with your disease segmentation. We looked at all of these layers and looked at which filter actually contributes to looking at lungs. Should we add a segmentation model? Could we turn off filters that look at bypasses, that look at pacemakers? So sometimes these filters can reveal a lot about what your algorithm actually looks at. This becomes harder the deeper you go into your convolutional network, because here I can still see that these are lungs and this is a spine. Here I can still see that. If I look at M and P, I have no clue. Like, this doesn't mean that much to me, but it is a good indication. And especially if you combine this, so R is basically the combination of all your filters. It is good to do them just to see if you're actually looking at what you're hoping you're looking at. That was it. So basically, your problem formulation is clinical question dependent. It's dependent on the disease and how your x-rays are taken. And you have to take that into account when you merge different data sets and where you get your disease classes from. For that, you need to take into account like the different views and different positions, because that very often indicates something about your disease status. Foreign objects might reveal more about your disease status than the disease present on the image. And you have to take a little bit of care when you go from grayscale to RGB.
Okay, that was excellent. For the people who are like, oh, we want imaging data, that's a very, very good talk. Maybe we'll take 2 questions so that Theo can come down and, yeah.
Thank you so much. So how to convert from CT, which has lots of slices, to RGB?
Okay, so for CT, it works different because in CT, you have all your window settings that you want to take into account. So for CT, it's just easier. We do a lot of 3D volume, so you give the whole volume in, to also add like the whole information about your window settings. So you have all of those intensities normalized. That's why you normalize it. You could do the same for CT as you do for X-ray. So for every pixel, you just duplicate the intensity, but then you have to normalize before. It's just a lot more work because you have a lot more pixels.
Okay, any last question or comment? Are you following at least? Yeah. Yeah. Marley, the question is, can you share your slides with the attendees?
I can probably share my slides. I'll figure out somewhere to do it.
Yeah, okay. She's going to send. Marianne?
When you are describing how the acute patients, if there's like 5 patients and one of them is really urgent, what stratifies to the one that's most urgent? Is it the clinical diagnosis? Is it somebody on the front end saying, hey, this patient needs to be moved up, or is it something in there?
So
algorithm.
What we see now is like, as an AI, what AI very often does, like we can do lung nodule detection, you can do pneumothorax. There are algorithms with AI that can do that. So there are algorithms now that say, hey, we search for like only urgent diseases. So we do pneumothoraxes, intracranial hemorrhage, like different types of diseases that you can see on CT or X-ray. And they say, okay, if we see a pneumothorax, we flag it, and then it gets a priority score, and it goes over a patient that the AI says this is normal. So it sort of prioritizes based on AI, which means it's very dependent on your AI accuracy.
So as you can see, it's not easy, right, with especially shortcut learning to figure out what's the right grouping of patients, and even more difficult if you're using the public data sets that don't have DICOM metadata, right? So you have to either really, really spend a lot of time. Marley looks at a lot of chest imaging, not just chest x-ray, to figure out what subgroup, like even just the support devices, which are not labeled this way, right? So quite a lot of ideas can just come from this talk about how to structure or think about different subgroups around chest x-rays. Chest x-ray is a workhorse. There are many chest x-ray data sets. If you're doing medical imaging, you're most likely going to use a chest x-ray data set just because of availability. But it's really difficult, including that today we don't know if chest x-ray AI can tell pneumonia, right? Because of just the complexity of even just having your normal be the patients who can stand, which is a mark of good disease, right? And the AI may just learn that. So another round of for Marley for coming.